welcome to the February installment of the Journal Club. Today we're going to speak about a hip-related or hip-focused topic. This particular paper was published earlier this year, February 2021, in the Sports Health Journal. And the title of the paper really is representative of the overall conclusions as they're interpreted by the authors. So that being that morphological changes of the hip commonly associated with femoroacetabular impingement are not correlated with rotational range of hip motion in elite soccer athletes. And as the authors highlighted in their introduction, morphological changes characteristic of FAI are common amongst soccer players. So their purpose and hypotheses. Their first purpose was to verify if morphological changes characteristic of FAI are correlated with a decreased hip rotation in asymptomatic athletes. And their hypothesis was that higher alpha angle values or acetabular retroversion index would be correlated with rotational range of motion of the hip. Secondly, then they wanted to determine if radiographic measurements or hip joint range of motion values would differ between a dominant and non-dominant limbs. And again, their hypothesis here was that there are clinical radiological differences between the dominant lower limb and the non-dominant lower limb in professional soccer players. So just looking at the methods for their selection criteria, so this was a single center study, so it was performed at one institution, namely the Sports Traumatology Center of the Federal University of Sao Paulo, and it was a transversal study. So this is the same as a cross-sectional study design, where the data analysed is from a specific population or a representative subset of that population at a particular point in time, and the particular point in time in this case was pre-season. So the inclusion criteria was professional soccer players. The age range was 80 to 40 years of age, and where written informed consent was provided. Exclusion criteria then was incomplete radiographic or clinical data. If there was previous hip surgery, if there was complaints of pain, or indeed if there was any pain experienced on clinical examination. The authors also did perform a sample size calculation in order to achieve a statistical power of 80%, an alpha value of 0.05, and a correlation coefficient of 0.35, which corresponded to a previous study which they've referenced. And the calculated study size or sample size was 62. The methods of evaluation then, a clinical examination of the hip joint complex was performed. A radiographic examination was performed, and this was in order to measure the alpha angle, which would represent cam morphology, and the acetabular retroversion index for a measure of the acetabular overcoverage. And both these were performed with patient supine. It was also the measurements then were performed by one physician orthopedist and one radiologist. And there was an interclass correlation coefficient for examiners also performed. Finally, then they evaluated the rotational range of the hip, in particular internal and external rotation, and they've done this using a goniometer. This was performed with the participant in the seated position with the knees flexed 90 degrees, and it was dual operator assessed. It was two operators, one operator passively rotating the hip to the end point, and then one operator measuring the actual rotation of the hip. And each measurement was performed 3 times, and the average measurement was taken. The results: there was 110 athletes who were subject to assessment, of which 59 asymptomatic male professional soccer players were included after considering the inclusion and exclusion criteria. The average age was 25.5 years of age, ranging from 18 to 38, and the majority, almost 75%, were right side dominant. Further questions. So in order to answer question 1, which was to verify if morphological changes were characteristic of FAI were correlated with a decreased hip rotation in asymptomatic athletes, overall they found that there was a weak correlation between the range of motion and the alpha angle in each limb. Further, there was a weak correlation between the range of motion and the acetabular retroversion index in each limb. There was a statistically significant p-value there for external rotation in the non-dominant side, but again, this correlation was weak. Question 2, so this was to determine if the radiographic measurements or the hip joint range of motion values differed between the dominant and non-dominant limbs. Overall, for internal rotation, total rotation, alpha angle, and the retroversion index, they found that there was no differences between the sides. there was a statistically significant difference between the dominant and non-dominant side in terms of external rotation. This difference was 1.5 degrees. However, when an additional Bonferroni correction was applied, this was found not to be significant. The limitations, as kind of described by the authors in the paper, the hip rotation was only performed in one position, this being the seated position. The study was underpowered. There was only 59 patients included, where the sample size estimated a required sample of 62. There was a lack of control group. There was also a lack of female athletes, and the data collection time point was also determined to be a limitation, this being pre-season, so it gave the potential for inaccuracy or underreporting of pain. In conclusion, then, both study hypotheses were refuted. So morphological changes of the femur as the acetabulum that are commonly associated with FAI were not found to be correlated with the available hip joint range of motion in these male professional soccer players. And there's also no significant difference between the dominant and non-dominant limb. Overall, the authors suggested that the anatomical FAI may not have a very strong influence on the available hip rotational movement in professional soccer athletes. So I'll pass it back over now to Mr. Carton to begin the discussion.
Okay, David, thanks very much for that. That's a very good overview of the paper. And so at this point, I think what we'll go through is we'll just take the paper in a structured approach. So I think the title is important to start with, because when I first read the title, it seemed to say to me that that's a FAI in a way, it was not correlated with rotational range of movement. But again, when you look at the title more closely, from the title we can understand that this is not a study undertaken on symptomatic athletes, and it only relates to rotational motion of the hip with respect to morphology, not other movements such as flexion or adduction, which also may be linked to FAI. So I think it's important, that you understand that and I think it takes a while to go through that title to really work that out. And but there's a very common way of presenting titles now is to almost to state your results with the title, and so the title is accurate in that it does state what the results were found in the study. So anybody, any comments on the actual title? Do you feel it's a good title, it's misleading, or any comments on when you first read the title?
No, so yeah, again, just the title is obviously representative of the conclusion, and it's, as you said, it is it's the standard kind of way that that people report titles now. So I think it was accurate. It can't be the title can't be. It's accurate for the results that were found in this paper.
Okay.
Yeah.
Okay. So the background, I think the background is very important. I mean, there is a lot of controversy over FAI, as we all know, and I think the distinction between symptomatic FAI and non-symptomatic FAI is often made relative to surgery, to non-operative treatment, to different assessments, and these findings of morphological abnormalities, are they a normal variant, or are they something that's going to lead to pathology later on in life? So the research question is very relevant, and it remains still unanswered as to how important is asymptomatic CAM or pincer deformity in this group of athletes. How important is it for us to look for it, to assess for it, and so the background is very important. I think it's good. So regarding the professional athletes, mainly male athletes obviously were involved in this, and they put that down as a limitation. Obviously, in our field, we deal with male athletes primarily. 80% of all the athletes we work on or more are male. So I think it is a very relevant population to look at the male athletes regards to FAI. Anything about the background, guys, that you want to add, or do you feel the background was in this paper was substantially written? Does everybody fully understand the controversies regarding the background with FAI, what they were trying to address in the study?
Yep.
Okay. Okay, David, look, what we do is we'll go, first of all, there's a couple of things with the methodology. We'll look at the methodology first of all, and let's focus on recruitment, okay? So 110 athletes were subject to clinical and radiological evaluation, yet only 59 athletes, after applying exclusion criteria, were involved in the actual study. I'm a little bit confused as to the reasons why they changed the exclusion criteria from 40 years of age to 38 years of age. That seems to have happened. There's no explanation for that. The other thing is that why did 110 athletes undergo radiological evaluation if one of the exclusion criteria afterwards was they having previous hip surgery or having symptoms or having pain on examination? Surely that would have been done first before they then took the athletes for a radiological evaluation. So to me, that was a little bit of confusing. I don't know what anybody else thought about that particular set of exclusion criteria.
Yeah, I just thought that it would have been good to have a breakdown of each of the exclusion criteria and how many athletes they lost out at each stage, because you'd like to know what were the reasons for such a big drop off. So that was the only thing that I had on that. And also it's a little bit unclear. It's a bit vague, complaints of pain and pain caused by clinical tests. I'd like to know a little bit more about that, what sort of examination techniques they used and what categorized as pain, I suppose, in that, or was it discomfort, or was it pain, or how did they quantify how much pain they had to feel, or just like a little bit more background into that.
Okay. Anybody else have any comments on the exclusion criteria?
Yeah, I think they touched on it in their limitations. The underreporting of pain, particularly pre-season. I'm doing a lot of medicals at the moment for League of Ireland players, and they're in their pre-season at the moment. And I often find that, when you start talking to them initially, they say, oh yeah, I've no injuries, no pre-existing injuries, haven't had surgery. But when you actually get into the nitty-gritty of it, they do have a lot of underlying issues. And I think, that might be one of the, they were initially recruited for the study, and then when they actually kind of got into it, did the examinations, particularly with the checking the internal and external rotation testing, that they actually were symptomatic and did have some underlying pathology that would have excluded them at a later stage.
Yeah, but would you not have thought that it suggests that 110 athletes were subject to clinical and radiological evaluations? So they have X-rayed 110 athletes, but yet they've excluded 51 of them. Based on the fact that they were symptomatic or previous hip surgery, or they also said if insufficient radiological or clinical information, but if they've only had one AP X-ray, so I'm not too sure how they'll have insufficient radiological data when they've only had one X-ray. So there are 51 athletes that really, as Michael has stated, that it would be nice to have a little bit more information as to why these athletes were excluded, on what grounds were they excluded for not having radiological information. And the other thing is that we see in most modern papers, when you're looking at it, when you've got a large fallout like that, we want to know more information about the alpha angles, the range of movement in the group of patients, or sorry, the groups of volunteers that you haven't included in your study, because it may have been very different and statistically significantly different than the group you have included to look at. So there's a lot of missing information there that I think certainly takes away from the recruitment of this group. Okay, any other comments there on that particular part of the recruitment of the methods section? Okay, just regarding the last thing in recruitment there, David, regarding the minimum sample size, obviously they did some form of power analysis which indicated that the sample size, or the minimum sample size that you needed to have adequate power for the study, was 62 athletes. They've excluded 51 athletes, and now they have 59 left, so it would suggest that they're now working on a sample that's below par. They only mentioned a website regarding regarding what power they did what power analysis on a website. I'm not too sure is the website that they've used an acceptable forum for working out your power analysis, or does it really matter how you do it as long as you're calculating the correct way?
Yeah, I think as long as you're calculating it using the kind of the correct the required variables that you need in order to establish a sample size, I think irrespective of the fact that it's on a website or if you do it by hand, I think it's appropriate. And they do in the paper they do provide a link directly to the website. As if you click on that link, it will bring you to the website that they use. But yes, as far as I feel that it's appropriate. They've used obviously metrics from or parameters from a previously published study as well, so which has shown to have the appropriate statistical power. So that they have used pre-published results.
Okay.
Which is a similar study. So.
Okay, radiographic analysis. I think again, does anybody comments on the process they've gone through regarding blinding the assessors and looking at inter and intra observer reliability and the accuracy of this? I mean, on the methods they've used in order to try and measure the X-rays. Is anybody any comment or like to elaborate on that?
Well, yeah. Again, I think the fact that they did use an interclass correlation coefficient and they did report that, it just showed that they've taken kind of the appropriate steps to try and validate the technique that they've used to measure these. Obviously, the interclass correlation coefficient, they've done two different kind of lines of analysis. So they're like an intra-observer correlation and intra-observer correlation. So they assessed the same measurements, 21 days apart, I think. So they were able to, validate how accurate their measurements and their measurement technique is. And it was shown to be quite reliable. I think greater than 0.8 in all the assessments that they've done. So, yeah, I wouldn't have any issues there.
Yeah, it said actually. Some of the accuracy between the examiners was exceptionally high. I mean, there was it was 0.96, I think, in one set. So, I mean, it would seem to be very, very high for a correlation between measurement of something that is quite inaccurate at times, such as measuring alpha angle. There's a lot of subjectivity to measuring the point at which a femoral head becomes aspherical, and so I was quite surprised as how much the accuracy was evident between the two examiners. So, but we have to take it as it is. The only thing I said is why look at the first set of 50 X-rays whenever there's only 59 people in the study? That sort of again was a little bit surprising. Why not just complete the study and look at everybody? Okay, so the alpha angle, as everybody knows, is a way of measuring the asphericity of the femoral head. That can be done on an AP view as done in the study. That can be standing or it can be supine, lying down. The other way of looking at it is looking at the done view, or an alternative view where you're looking at the anterolateral femoral neck, which gives you, in most people's view, a better estimation of the true size of the cam deformity. It's like when you're measuring a cam deformity on an AP X-ray, it's like trying to measure the height of a mountain from a helicopter, and so you're looking down on top of the projection. So you're looking more of the width of the base of the cam, in my view, rather than the true prominence of the cam deformity, which again, in my view, may be more relative to restricting range of movement. So picking the AP view was obviously they've stated why they've done that from ease of it required one X-ray. They could also look at the acetabular retroversion index on the same radiograph, so you can understand the methods why they've selected that X-ray, but it may lead to inaccuracies in measuring the true size of the alpha angle and the cam deformity. The only other thing I picked up there was the difference between standing and sitting. That there's a 3% difference reported before in measuring the cam deformity or alpha angle on a supine X-ray as opposed to a standing X-ray. I'm not too sure how that 3% difference would have made with respect to the study. Probably unlikely when comparing all within the study rather than outside of the study. So, any comments on the actual radiographic analysis from anybody?
Just on that, Pat, are you familiar with, is there research looking to compare the AP view versus done view in terms of, is there a consistent direction, as in one tends to be larger than the other?
The AP view alpha angles tend to be larger than the done view, but they are well correlated. Even some of our own papers have demonstrated clearly that there's a good correlation between the two, but again, some of our own work would suggest that the done view is a more accurate estimation of the cam with respect to a pathology in the hip, with respect to range of movement, with respect to outcome. So again, it's and the vast majority of the deformity is definitely not visualized on an AP X-ray. So that's one of the points I think that weakens the true accuracy of the study is the only one measurement of the cam or the alpha angle on the AP view. Okay, any other comments on or anything that anybody wants to add regarding the methods regarding radiographic analysis between the assessors or the method chosen to measure the alpha?
Not really with the alpha angle, but in terms of the acetabular overcoverage, you know, the fact that they did take an AP X-ray, it's kind of a bit surprising that they didn't measure the lateral center edge angle, which is kind of more commonly used to assess the degree of overcoverage. Yeah,
again, or at least utilize both measures, because obviously the lateral center edge angle was originally designed as a measure of undercoverage as opposed to overcoverage. You know, so what degree the lateral center edge angle allows you to estimate anterior pincer deformity is questionable, and so I think looking at the size of the rim, looking at the acetabular retroversion index is probably a reasonable way of looking at the anterolateral rim. But again, it depends on the quality of the X-rays. In many X-rays, the quality is difficult to see the true border of both the anterior and posterior wall of the acetabulum as it tracks, especially down towards the medial aspect of the joint on the AP view. So you lose that. I suppose the contrast is often difficult. So it's a difficult one to measure, I think. You know, so. Okay, so but I agree. There's other things, other areas of the AP pelvis that could have taken into consideration, such as the crossover sign, the ischial spine sign, you know, different, you know, the posterior wall sign, different levels of retroversion that they could have brought into this to look at the relevance and correlation with range of movement that they didn't. So they've gone for picking one measure, okay, so. We'll move on then to just the rotational analysis, looking at axis range of movement. And I suppose first of all, from range of movement, maybe we could ask Derek or Michael to have any comment on what they feel, whether this is an accurate way of measuring rotation in the hip, as opposed to measuring people who are lying supine on the couch with the knee and hip flexed to 90 degrees. I have my own views on this, but I'd be interested to hear your views.
Yeah, I suppose I would probably be inclined to say measure them in the supine position and actually have maybe a pressure biofeedback unit or something under the lumbar spine, and you can really control the lumbar lordosis or anterior pelvic tilt quite easily in that position. When they're sitting up, I think you could gain 20 degrees of extra flexion by just sitting up straight versus slouching in your chair. So, you know, and that will make a big difference in the internal rotation. If you're sitting right at 90 degrees of hip flexion, it's really going to limit your internal rotation if you had some sort of morphological change. So I would at least they should have potentially just given a little bit more detail on exactly how they limited that lumbar flexion extension, or I suppose pelvic rotation or whatever. So little bit vague there as well, the position that they used and how they regulated and standardized it.
Okay, Michael, Derek.
Yeah, I agree. First of all, I think the attempt to kind of reduce or eliminate any errors in measuring it by using two people, which is important. They did use a goniometer to use it, which we know has been validated and shown to be reliable. A lot of studies now are starting to use the kind of electro goniometer, and again, that's kind of shown to have a fairly strong correlation. But I think in a clinical exam, in a clinical setting, you know, to use a handheld goniometer is fine. I think there's more kind of studies showing that from a study point of view or a kind of lab from an evidence point of view, that maybe the electrical goniometer may have been a little more accurate. On the position of the athlete, again, like as you were touching on, Michael, there's been a couple of papers kind of recently produced. One has been been released in the Journal of Sports Medicine on the effects of pelvic tilt. And looking at internal and external ranges of movement, and there's a significant difference, and they found a significant difference in a seated position with pelvic tilt or pelvic posterior tilt versus anterior tilt, to almost 6 or 7 degrees that they found extra internal rotation. So that's really important, and haven't really kind of gone into detail about how they tried to eliminate this. They did say that like the seated position was chosen to avoid lumbar compensation. but that was about it. They didn't give any research or they didn't go into it any more detail. Also, it's a bit vague in the sense that the athlete was positioned sitting at the examination table and stabilized with a belt. So I don't know, it would have been good even just to have a picture of the setup to see exactly what they were doing. So for me, from that, I'm kind of trying to think, what does that mean, sitting at the examination table, and what did they try to do with the belt? Was that over their thigh? It's just a bit vague, and actually the setup. So I would have liked to just seen a picture, maybe that would have given us a little bit more detail.
Okay. Anybody else? Any comments on the positioning or the methods of using range of movement analysis? Happy enough. So look, yeah, I agree with what both you guys have said. I think the my preference is to measure internal and external rotation with the patient supine. I feel once you have the patient lying flat, you can hyperflex the contralateral limb beforehand. It'll give you that a flattening of the lumbar lordosis before you then bring the hip back into 90 degrees and then look at your internal and external rotation. So you're replicating the same maneuver with each of your patients. I think when people are sitting, as Michael says, people will assume very different levels of pelvic and tilt and lumbar lordosis depending on what way they're sitting, and that will affect their internal rotation. The other thing is when you're sitting and you assess internal and external rotation, the hip falls very easily into extension. You can extend the thigh into the seat very easily, and with extension you will increase your internal rotation. The knee also can go into adduction, which will increase your internal rotation. And the other thing they didn't take into consideration was the varus and the valgus strain of the knee, because especially when you're measuring movement passively, once you bring that movement into the extent of the range of movement of the hip, the knee will then drift into more valgus and can add 5 degrees more to internal and external rotation very easily. So there was no comment on how they controlled for valgus and varus strain of the knee, and or allowing the thigh to drift into extension or the knee to drift into adduction. So for all of those reasons, I think it's more reproducible to do that with the patient supine. The belt, again, I'm not too sure what they were using with the belt. Well, that was just to support the patient on the table, or to, I'm not too sure that they didn't describe that properly.
There's been a number of studies looking at the kind of range of movement being assessed in a seated position, but most of them have been done in like in a biodex chair where they're completely supported and you're fixing that position in. So again, kind of from trying to reproduce it, at least there's some sort of standardization there. But with this, again, a picture would have been really good just to see.
Okay, what about the actual? Let's now talk on to the about the results then. Okay, so the crux of this matter is looking at the rotation versus looking at the X-ray. So we've looked at that in a lot of depth. So let's just talk a little bit about the actual results. First of all, if we focus on the alpha angles, David, maybe you might sort of talk to us a little bit about. My feeling was that the alpha angles for an asymptomatic group were very high, and not only were very high, but the minimum alpha angle was higher than the mean of a male athlete that's considered normal, which is less than 55. And so if a whole group had an alpha angle of higher than, I think, 60 something, I can't remember exactly what the figure was, but it was well over 55 degrees, then we're dealing with a subset of a sample that should have been more representative of the whole range of movement, or sorry, the whole range of alpha angles that you'd expect from an asymptomatic population. So half of the patients on average should be below 55. So what are your comments on that, David, or in respect to some of the work that we've done ourselves and some of the movements that we've measured, how do they compare?
Yeah, no, I noticed that now myself actually in that table 4, that the every case seems to have what we could consider a cam deformity. So they're all well above and almost 10 degrees above what we consider normal. In relation to, I suppose, the guys, or people we see coming through the clinic, it's still a lot higher than a lot of the people who we operate on, or I don't operate on, but are operated on. So obviously, we have our institutional registry and everything in that database, and a lot of the unilateral patients that would come through, asymptomatic or symptomatic just on one side, the asymptomatic side, I suppose, would be representing or most comparable to this study cohort, and the alpha angles would be about 10-15 degrees higher than what we would see.
Okay, yeah, I've got some of the results that you'd sort of sent me on our, just to let everybody know. When we look at the AP view pre-op, the mean alpha angle in our symptomatic hips is the operated hip. The mean is 63.9. Okay, as opposed to the mean in this study, which is 83.6. So, as David said, approximately 20 degrees more pathological in this asymptomatic group, and then in our non-operated hip, the mean AP alpha angle is 58. So again, the mean obviously is closer to what you'd expect is normal, which is considered to be 55 degrees on the AP view. So and again, the dominant and non-dominant sides in the study were both significantly higher. In fact, the lower range, actually the lowest alpha angle measured in this asymptomatic study was 69.4 on the dominant side, which is higher than the average of our symptomatic operated patients. So which seems to be very, very high. And so the other thing is the range, which is more important than the actual mean. The range here is going from essentially 70 degrees to 80 degrees. So it's a very narrow band of alpha angle that's being measured. So to be able to try and get some degree of correlation with a wider band of range of movement would be very difficult when you've got such a narrow level on one side of the results. So what you'd expect to see there is a range from maybe 30 degrees right up to 100 degrees with a mean around 55 in an asymptomatic population. So I know they're professional athletes, but nevertheless that there should be a much wider range there, and that would allow a better analysis with correlation with range movement, I feel. So for whatever reason, the alpha angles were particularly high. Anybody any comments on that, or anything they want to say about that?
I support your point, Pat. I think it's the point that stood out to me most from the paper was the high alpha angles and the range being quite small. As you said, it's a little bit larger, I think, than you just said there. It's about 70 to 95. The maxes are 96 and 98.
Okay, yes.
But you're right. It's still a very narrow range. And if you had the data on those that were excluded, you would have to assume that they're in the hundreds, 110, 120. Some of those possibly would be if they're excluded over pain-related issues. If everything's been shifted up by 20 degrees for some reason, I'd like to know how an alpha angle, how the data gets. Do you have any understanding or explanation of how the alpha angle could be so much higher?
It's
anything in the methods they use?
Yeah, well, again, it's they've described the correct way of measuring the alpha angle, and but as I've said, the point at which you select as the point at which the head becomes aspherical is very subjective, and I think much more so on the AP view than on the done view. So when you have a done view, the alpha angle, I think, is much clearer to pick the point at which the head becomes aspherical. On the AP view, there tends to be this flattening, and rather than a defined point at which it becomes aspherical. So that an area of flattening is very difficult to pick, and I guess they're going very, very high in towards the joint in order to establish that point. So again, it's difficult. It depends on where you place the center of the femoral head, and when you've got a femoral head on an AP view that is flattened rather than a very clear spherical femoral head, then again, it's difficult to pick that central point as well. And so I think it probably comes down to a certain amount of examination or evaluation error, in my view, because I think the results here would be a unclassical, not classical of what you'd find in most of the literature. Okay, so let's move on to the results on the range of movement. And the fact, if you look at internal rotation, a correlation with alpha angle. I mean, on the dominant side, it's a positive correlation, and on the non-dominant side, it's a negative correlation. I obviously agree that it's negative and it's 0. So, but does that mean anything when you have on one side you have a positive correlation, on the other side you have a negative correlation? Does that just substantiate the fact that there really is no correlation either way?
Yeah, I think probably the size of the sample, and maybe there could have been a load of outliers. I mean, that particular test is pretty sensitive to outliers. So yeah, I'd imagine based on their hypothesis, and you would expect to have a kind of a negative correlation anyway. So you'd expect that as the degree of deformity, or the morphological kind of deformity increases, that your range of movement would decrease, and that's what would kind of signal your negative correlation value. But
okay.
When the R value is so small, you're essentially talking about a flat line, and therefore a flat line can be a flat line with a slight slope upwards, positive, a flat line with a slight slope downwards, negative. So the fact that one flip-flops to positive and negative is not surprising at all when the R values are so low and the P values are so high. So these are very far from statistical significance, and also have very low strength in terms of the weakness of the correlation.
Okay, and there's one correlation, external rotation, the difference between a retroversion index and the dominant and non-dominant side. So external rotation, the non-dominant side appears to have a positive correlation, which again is most unusual, because external rotation is the one range of movement that you wouldn't expect to correlate with any form of impingement. External rotation moves the femur away from the zone of impingement and rather than towards it. So it certainly wouldn't be classically correlated with any abnormal. You wouldn't have a correlation between external rotation generally and an impingement deformity. So it's a bit odd that that's the only one that seems to have some sort of statistical significance.
And am I right in saying in this case it's saying that a greater amount of external rotation is linked with a greater retroversion index? That's what the positive correlation is here. So yeah, okay.
Okay, so looking at the actual range of movement measures, and so again, that caught my eye, because internal rotation is the one we want to focus on, because it's the movement that is most classically limited by symptomatic FAI. So, and if you look at the mean internal rotation, it's 46.8 in both sides. So I mean that's an enormous amount of internal rotation, and so I mean if we go back to our own, I think David, you have some of the numbers from our own cohort.
Kind of the most comparable cohort would be kind of a male competitive athletes, unilateral patients. So we have a symptomatic side and an asymptomatic side. The mean internal rotation for the symptomatic side for patients that are coming through would be 23 degrees. Prior to surgery, and then the mean internal rotation for the non-operated hip, or the asymptomatic hip, would be 27.6. So in this study, it was mean internal rotation was about 46 for each side.
So again,
20 degrees is different.
So again, and if you look at the literature generally, and we've looked at some of the normative data in male, Caucasian patients in this age group, and internal rotation is approximately 22, 23 degrees. So I think certainly the cohort values in our registry would be very much in keeping with what's found in some of the papers. This 46 degrees mean seems to be very, very high. And again, this could come down to the technique. I think that they've made a good attempt at using a single person to move the limb, and the second to use the goniometer in my view, is a correct way of doing it. But again, in the sitting position, I think to get that level of internal rotation, the hip has drifted into a extension, the knee is drifted to adduction, and they've incorporated some increased strain of the knee, valgus strain of the knee, because it's a very high. We'd expect that in that sort of level of internal rotation in sort of somebody who's got hyperlaxity of the joints.
I think particularly.
So, any other comments there on?
I was just saying, I think in particular when the alpha angle is 88 degrees or 83 degrees on average as well, it's a particularly high internal rotation value.
Yes. Okay. So has anybody any comments on anything regarding the actual results there?
Not really. Again, it was just the fact of the range of movements. There were, as again, it's something typically we'd see that kind of 25 to 30 degrees of internal rotation, and then even just commenting on the external rotation, it's so small. Like for it to be kind of the mean to be kind of lower than the internal rotation, just stood out to me as in I just wondering again what kind of technique they used, and maybe there was some variance in thigh movement and or hip to correlate or to kind of match up to those numbers, because they just don't make sense.
The other thing is that the lower end of the range of internal rotation is 20 degrees on the dominant side and 21 degrees on the non-dominant side, which is sitting around what our average is, albeit for our symptomatic patient, but it's not that much below the average for our non-symptomatic patients or hips, and so but the range going from 20 to 68 is I think a more representative range, nevertheless, compared to the range we have in the alpha angles, which is much narrower. So the range seems to be artificially high, and in the alpha angle seems artificially high and artificially narrow. So I think this is probably the reason why it would be very unlikely for the study to get correlation between these two measures. Okay, David, let's just move on to the conclusion then, and let's sum it up. Else, any comments on the conclusion derived? Everybody feel that that's an appropriate conclusion based on the way they've conducted the study and the results that they found?
Yeah, I think so. But I think just one point on it's a more of a minor point on the Bonferroni correction, the comparison between sides. I know that we didn't focus much on the comparison between sides, but it's a little bit disappointing when authors use a statistical approach in one section of the paper to say something is not significant and use a different approach in a different part of the paper. So in this paper, the abstract says there is a difference between the sides and doesn't mention anything about Bonferroni correction. And in the results, it says there's not a difference between the sides because they've used that correction. And Bonferroni is a very crude tool in terms of dividing your p-value and bringing it down. But I think you either use it or you don't. And it's confusing when the abstract says one thing, the conclusion says something different in terms of the comparison between the sides. I know that's not our main focus, but
just regarding the Bonferroni correction, I mean, at what, if we're doing statistics and we're looking at the comparison in a similar comparison that they've done, at what point in time do you introduce a Bonferroni correction? What makes you make the decision that you need to actually correct anything?
Yeah. My understanding, the reason it's brought in, it's a cautious approach to reduce the chance of a false positive, so a type 1 error. And type 1 errors, false positives, are more likely the more comparisons you make. So if you were to look at every county in Ireland and compare all 32 and everyone got a comparison between every single county in that way, that's a huge number of comparisons. In this case, they have, I think, 9 different comparisons variables when they're comparing left and right, and the 3 different variables. So they've decided to reduce their p-value down by dividing it by 9.
Okay.
And it's very crude in that way. It does reduce the chance of a false positive, but it increases the chance of a false negative. It increases the chance that you'll have found something at p.01 and you'll now say that it's not significant. The reason you're saying it's not significant is because we've made some other comparisons which are not even related to this comparison.
Yes.
It's a difficult one to you can't increase or you can't decrease the chance of the false positive without increasing the chance of the false negative. So they have used it and then not used it, depending on which section of the paper you're looking at.
Yes. Okay. So your comment really is that they should have been more consistent in their statistical approach.
I think so. Yeah. The abstract should certainly match the rest of the paper.
Okay. Okay. So I think looking at this paper, I think the methodology was generally very good. I think the statistics they used were appropriate. I think the conclusions that they have derived from their methods and the results are appropriate. I think the title supports the conclusion. So I think that the study has been undertaken well. The areas I have a little bit of I'd just be a little bit more cautious about is the angles that they got for their internal rotation and the angles used to look at the distribution of the alpha angle, and made it very, very high. And to me, the most important thing that's missing in this is the information on the 51 patients that were, or volunteers that were excluded. You know, they should have given us more information as to why they're excluded, and given us the information on their alpha angles that were measured and on the range of movements that were measured, so we can compare the sort of the people that were included versus those who were excluded. So I would certainly, after reading this paper and going through it, I don't think it would change my view a lot that there's no correlation between an increasing alpha angle and a range of movement. I don't think this paper has the accuracy to be able to determine that, you know, so that answer or the answer to that question still remains controversial. Okay, thanks very much, guys. We'll call it a day there, and we'll look forward to seeing you on the next Journal Club.